person. First of all, I would like to express my deep gratitude for the kind invitation to be part of this extraordinary Congress. Well done, congratulations. Again, plus I'm really happy to have the chance to get to know a little bit of your fascinating country, your generous hospitality, so it's a real pleasure. Thanks for having me. Salahadin, thanks a lot for inviting me to this on behalf of AOSpine. I was asked to give a talk about how to get the best clinical and legal outcome in Cauda equina syndrome. I have nothing to disclose. I'm chairing the AOSpine Knowledge from Trauma. I'll become the next AOSpine Research Chair. I'm really looking forward for more research coming from this area of the world, and I would like to support this. I'm an orthopedic surgeon. I'm chairing an interdisciplinary spine department in Erlangen, which is close to Nuremberg, which is in Bavaria in Germany. Interdisciplinary means that under my lead, neurosurgeons as well as orthopedic surgeons work together. As I said, I have nothing to declare, no disclosures. Cauda equina is a relatively rare condition. Less than 5% of all disc operations have the indication of Cauda equina, and the incidence is relatively low and differs between regions. At least for Europe, I have some data. Scotland has the highest incidence, while Slovenia has the lowest one. So I will a little bit shed light on this later. Since it's a rare condition, we face a couple of problems which are not easy to answer. So the question is, for instance, what is the significance of delay in diagnosis and refer to hospitals? What, for us as surgeons, are the benefits and risks of emergency versus urgent surgery? Should there be a time window, like less than 24 or more than 48 hours or whatever? And what about the prognostic significance of complete versus incomplete sphincter as well as sensory deficits? And of course, the medical legal implications of the above. So starting with the medical legal implications, which is one of the tasks of this topic, I have to confess that there are very few data coming from Germany. So I reached out and I found data from Andreas Dimitriades. He's a neurosurgeon from Edinburgh in Scotland. And he provided me with this data because in the UK, in the United Kingdom, this is a real epidemic disease, interestingly. Over the last 5 years, 80 Cauda equina claims have been fought out, and the average compensation was about £200,000 and settled up to 2 million. So that's a huge amount of money. And in the UK, they have already brochures like on the right side, telling the doctors what to do in Cauda equina syndrome to get out of this problem that people see you afterwards. However, due to the high limitations and numbers of limitations, the medical defense unit had already stopped providing cover for neurosurgery and spine surgery. So at least in the UK, it's a real problem. How to define Cauda equina syndrome? There are a couple of definitions out there. Maybe the most common one is the one from Fraser, whereas either bladder and or bowel dysfunction, a reduced sensation in the saddle area, as well as sexual dysfunction with possible logical deficit in lower limbs. Pain is not necessarily a symptom of Cauda equina syndrome. Can be, but more important is the bladder as well as bowel dysfunction. There are different onsets, different variations of onset of CES. It could be a rapid onset without a previous history of back pain. It could be acute bladder dysfunction with a history of low back pain and sciatica. And the patient could have already chronic backache with sciatica and then gradually progressing CES, mostly coming together with a canal stenosis. On presentation, that's kind of important. More than half of the patients have already urinary retention. We call this a CESR, while less than half of the patients have an incomplete syndrome, a CSI. That's important to distinguish because there's from a prognostic point of view. In a recent systematic review, 52,000 patients were included, coming from 110 studies. Looks dramatic, like, well, that's a lot of data, but unfortunately, the definition was different, was not even throughout the studies. The study methodologies were not that good. So some conclusions can be drawn by looking at this systematic review. First of all, disc herniation is the most common cause for a CES, followed by trauma, degenerative, tumor, and other postoperative complications. And the typical surgical procedure is a laminectomy, followed by microdiscectomy, a combination of laminectomy and discectomy, and only 10% get an additional stabilization. When we look at the timing, we could say, okay, maybe time is fine, but is this really in CES like this? 20 years ago, Ahn et al. Promoted that surgery should be done within 48 hours because their results showed that everybody got surgery within 48 hours were better than the ones afterwards. However, a couple of years later, other authors questioned these data and said, well, when we look more in detail to the data, they really said maybe it's even better to decompress the patient within 24 hours. So later on, with other systematic reviews and other studies coming out, the role of this urgent surgery within 24 hours remained a little bit controversial. However, obviously, some series claimed improved outcome from emergency decompression, while others not. What we can say, of course, is that an operation performed under less optimal conditions, like in the middle of the night, would probably increase the complication rate if somebody does it who is not really familiar with the technique and maybe you have not the right skills to do so. What you should keep in mind if we deal with Cauda equina is that experimental work has shown that an ischemia for more than 6 hours is mostly not reversible, so there's a real damage of the nerves. Let's look at some more studies in detail. Here's a study with 50 patients, and they had a mean delay of already 12 days, so relatively long after the onset. However, the authors found a positive correlation between the duration taken for total recovery and the delay in surgery. And, interestingly, they found an improvement even with decompression, even in those patients presenting late. Just promoting decompression every case, even though the patients come up like 12 days later. Another prospective study, including 33 patients, found no difference in outcome in respect to the length of time from symptom onset to surgery. So they found no correlation whether the patient got emergency, urgent surgery, late surgery, or whatever. So what they found is that there was a better outcome when the patients were continent of urine at presentation. So this is obviously very important. What is the status of the patient when he shows up? And interestingly, the duration of symptoms did not appear to influence the outcome. So even if the patient had already like a couple of days urinary retention, there's still a chance for them to recover. Another study, 56 patients, they found out that symptoms duration before operation, again, like the other study, did not affect the outcome at 2 years. However, the outcome was not good in general. So patients who had CES did not fully return to normal status. When we look more specifically to urinary function, meta-analysis published found a difference whether the patient had complete retention, so showed up already with the need of a catheter in the emergency department, or were not complete. So the ones who were not complete had better results in terms of recovering urinary function. Another systematic review looked at the long-term outcome, and they looked, for instance, at the micturition. 409 patients were included in the systematic review, and after the minimum follow-up of 17 months, 42% had still micturition dysfunctions, ranging from 13 to 19%. And that wasn't really better with the defecation outcome. Prevalence of defecation dysfunction after 17 months, almost 50%. Again, range from 10 to 90%. And when you look at sexual dysfunction, the prevalence here was 44%, again ranging from 10 to 75%. And definitely sexual function is underrated because typically, the patients do not report about this that freely. So what happens to patients who may have or present with the CES but have not negative scans? That's interesting, and here again we can look at the Scottish data, and again I'm gratefully that Andreas gave me some of his data, because in Scotland it's obviously quite common that people present in the emergency department with a CES, but 70% of them were scan negative. So in Scotland, he told me, more or less every day somebody shows up in the emergency department having a CES or presenting symptoms like a CES, but only very few have it indeed. And they looked at the patients who were scan negative and scan positive, and 90% had a Hoover sign. I'll just explain you in a minute what it is. They had more panic attacks, dissociations, and nerve root compromises. What is a Hoover sign? Maybe you may remember from your time when you went to medical school. Hoover sign means that if you ask somebody press down with the heel while lying supine or sitting, and he says, I can't do this, you ask them to lift up the healthy leg. But when you lift up the healthy leg, automatically your heel presses down. It's involuntarily. So then you can distinguish whether the patient has a real paresis or not. Anyway, patients with scan-negative CES had more positive clinical signs of functional logical disorders. So their symptoms, they feel they are real, but they are not due to a spinal pathology. So this can happen as well. Well, so to answer the question, how to get the best clinical and legal outcome in Cauda equina syndrome, we have to confess that they have inconclusive literature when we look at it, but there's an evolution in literature which shows the following. 20 years ago, there was the understanding that we should discriminate between incomplete and retention, and that the incomplete one would have a favorable outcome after early surgery. However, the ones with a full retention probably do not recover and would not so much profit from an early surgery because they said the die has already cast at the time of the prolapse. 20 years later, the current data, here a study from Scotland again, 622 patients, 21 patients in a prospective multi-center study, showed that bladder outcomes and disability were associated with the severity at presentation, but not with the time to surgery. And the disability at 1 year was associated with the disability at admission. So today, it's obvious that the current data more show that the current data do not support the suggestion that any kind of 24 to 48 hour time window really leads to a better outcome. So what is my personal conclusion and advice? So I would say if anything is incomplete, I would suggest immediately or at least urgent surgery and should not really prolong this, so ideally as soon as possible. And this is, I think, at least in our environment, is possible. It's immediate or urgent surgery. However, if patient needs already a catheter, then surgery is still meaningful and should be performed, even if patient had a duration of symptoms for like 10, 12 days or whatever. Still, surgery is meaningful, but it's not time critical anymore. However, you have to inform your patient that long-term dysfunction of micturition, defecation, or sexual function is unfortunately extremely common in about half of the patients. So that's what the patient have to know when they show up with a bladder dysfunction or whatever. So tell them unfortunately, whatever we do, there's almost 50% chance that you will have some impairment over time. Thank you very much.